Hey guys, what's up? It's Dr. J.
I'm Dr. I, and this is Second Opinion with the Twin Doctors. Doctor, what's in the news?
I'll tell you what's in the news. It is the big, beautiful bill, this 900-page bill that is going to affect so many aspects of American life. But our focus is on how it's going to affect healthcare and healthcare education. Now, normally we start our shows by doing our little Doctor, what's in the news, but we're going to save that for later because we have got the most amazing guest. Me? Here, no, not you.
Oh, okay.
We've got the most amazing guest. We're going to launch right in with her. This is Dr. Monica Sango. Now, today we're going to be talking about missed it by that much. The top 5 missed diagnoses in U.S. healthcare. And we have a doctor who knows a thing or two about that, not because she's missed diagnoses, because she is absolutely amazing, but because she is a board-certified emergency room doctor. Not only is she a board-certified emergency room doctor, she is the director of emergency medicine at her hospital in Georgia. And to boot, she is a journalist with quite a few credits to her name. She was even a journalist, she was even a medical contributor for a local Fox affiliate in Georgia.
Right, that's right.
So she is an amazing guest, and we're super excited to have her. Dr. Casango,
Yes.
welcome.
Thank you. Thank you
So
so much.
a little background of Dr. Sango, right? We
Yes,
all went to
yes.
med school together.
Yes,
We did.
We
Like
went
5-6 years ago.
maybe
Or
more
maybe-
like
maybe
20,
20?
25, 20,
Quiet.
25 years ago. So we went to Rush Medical College, the oldest medical college in the state of Illinois, and dare I say, the best medical school on the planet. It produced
Absolutely.
us three. All right,
Yes.
there you go. All right,
Yes.
so
It's like getting the band back together.
exactly, getting the band back together. Exactly. So let's get right into it. So I feel like when people think about medicine,
Yes.
they think about the ER.
Yes.
You have shows like The Pit.
Yes.
You have ER.
Yeah.
It's all about ER. I even thought I
Right.
wanted to go into ER because of ER, right?
Right.
So everybody wants to know what it's like in the ER.
Right.
So what is the average day like for an ER doc?
Okay. So disclaimer: I've never seen any of those shows.
Oh, well,
Just to be clear.
Are you busy?
Yes.
Right? Okay,
Too
got it.
busy. So the average day, actually, so I work in a smaller volume ER. But we're part of a larger system, but average day is actually pretty busy. So I see everything that ranges from, a cold or sinus infection to somebody who's having a heart attack to somebody who has a collapsed lung to somebody who's been in a car accident. So it can start off with a bang, or it can start off with just very chill. I can walk into a room, an emergency room that's, just got some small kids crying, maybe somebody with, a small cut. There's a lot of, where I work, it's pretty rural, so I see a lot of injuries, a lot of, tractor injuries, farming injuries.
I was
lots of
literally going to say tractor injuries.
Lots of farming injuries, things that I wasn't necessarily prepared for. Things with machetes and, table saws. So I see a lot of those kind of injuries. And while you walk in and you think, oh, it's not too busy, the problem is those take a long time to take care of.
Yeah.
I would imagine a table saw injury would not be quick.
You can't just put a little glue on a machete.
No,
in there,
you
right?
cannot. No. Or put some, Epsom salt on it. I can't do any of that.
It's so nonchalant. Table saws like
Machete is. Yeah.
So it can start off that way, and then it usually progresses from there. So I end up seeing, you can end up in a 12-hour period seeing almost 24 to 30 patients.
Oh wow.
Yes.
So when we say emergency room, we think of emergencies, right?
Yes.
Do you feel like most of what you do actually are emergencies, or are you doing a lot of primary care as well?
So that's a great question, because when we started our career, emergency medicine was truly about people coming in for what we would consider the emergencies: heart attacks, strokes, appendicitis. Things like that you need emergency
You can't
at
wait
that time.
for.
You cannot wait for. I think as we've evolved as a society in terms of our healthcare system, it's sometimes difficult for people to access.
Evolved.
Well, evolved, or maybe devolved.
Yeah, I was gonna
or maybe
say.
devolved. Is that people are, I'm seeing a lot of primary care situations. So I have to be well versed in how to take care of people who are diabetics that cannot get a hold of their insulin. I have to be versed in people who have high blood pressure, who haven't taken their blood pressure medicine in a year. So I do end up seeing a lot of things that are what you would consider primary care.
Why do you think you're seeing so much primary care in the ER?
So I think it's multifactorial. I think that the emergency room at this point is one of the few safety net places that have not been sort of stripped away.
Right.
I mean, it's the only place, it's one of the few places that you can go where I cannot ask you about any of the issue. I can't, it's not a matter of being able to pay. Like we have to see you.
Can't turn them away no matter what.
Based off of the EMTALA laws, which there are laws that basically say that everybody that presents themselves to the emergency room has to at least be seen and be medically screened, and so they have to be seen by someone. So that's number one. And number two, I just think that we're particularly in some places that are, rural places, it's difficult for folks to access their primary care physicians, and it gets difficult also with transportation. I mean, we're here in Chicago, transportation's not really an issue, but when you go out to places that are further out, not every place is accessible by a train or a bus or a cab or an Uber.
And you raise a good point about,
So-
you can't turn people away based on their ability to pay, right?
Right.
Because there's the EMTALA law, which basically says you've got to treat people.
Right.
And we were talking
Or
before.
at least stabilize.
Or,
Stabilize.
Yes.
Yeah, you have to stabilize them, yeah. And when we were talking before the show, you mentioned that, a lot of people come to the ER in part because they have medical debt.
Yes.
And so they have primary care docs, they maybe haven't paid them, and,
Yes,
when it's not an emergency setting, you can say, I'm not going to see you because you owe me money. But in
Absolutely.
the ER,
I cannot do that.
all right.
And I think that everybody knows that they will get, at least with my ethos, is that they know that if they come to see me, they will get the best care that I can give them, despite whatever the issues that are.
Right.
I mean, it just doesn't matter. So those are some of the main issues. I mean, and I know that people complain about wait times in the emergency room, but it turns out that sometimes the wait times are less in the emergency department depending on what time you get there. So you could be seen sometimes quicker by me.
Right, then your primary care doc.
Yes.
Yeah.
Yes.
So what are those prime times? If somebody wants to know, what's a good time to come to the ER to see Dr. K? Is it like between 2 and 3 on Tuesdays, or?
So it's never on a Monday. I can tell you that. But usually, I mean, I'm being super general right here because this changes every day.
Yeah.
But generally speaking, if you start off in the morning, it's, folks are, I mean, you come in at 7 o'clock or 6:30 in the morning. Are there people still there? Maybe, but usually you can be seen pretty quickly. But like I said, very general.
And it's crazy that like, it's a Monday, for example, that is the busiest. Because that tells you that a lot of the stuff you're saying is not an emergency, right?
Right.
Because if they could wait until Monday,
That's
it
right.
wasn't an emergency. And
Right.
so that tells you that a lot of folks are coming in for things that aren't necessarily emergencies.
And we even kind of see that in OB. Like OB triage blows up on Sunday night. Sunday night before people have to go to work. They're like,
Right.
oh, this has been bothering me for a few days. Let me go get it checked out. So it's just it's a thing.
See if I can get a note, maybe get another day or two
Okay.
off,
So I don't want to be as cynical as that, but the fact is, people do ask for notes. I mean, they're like asking, I'm here. It's a Monday. I've been seen. Can I get an excuse?
You're here. You got that notepad? Maybe,
I'm going to give you my cynic's hat. It fits quite nicely, actually. But okay, well, so what we were intending to talk about was medical errors, right?
Yes.
I was looking at some stats that showed that recently in ERs, but I would imagine this is probably across all spectrums of medicine, about 5.7% of encounters will be encounters in which there's a medical error.
Yes.
Do you think that number's legit, or do you think it's higher than it actually is, or lower than it actually is?
I actually think it's probably accurate.
You think it's accurate?
I do.
Okay.
I do.
So 1 in 20.
And,
okay.
Yeah. And I'm not. I feel that I give really good care, and I think that my department is because we work very hard to be diligent and to, work things up. But I think the expectation now, one of the other reasons I think we're seeing a lot of patients is because I think there's an expectation that you're going to come to the emergency room and you're going to get a full workup of whatever issue you're dealing with, so you don't have to wait.
Yeah.
So, because of that, I think that we're seeing more people.
Yeah.
Volumes are going up. So yes, the
Yeah.
percentage of errors is high, but you also have to look at it as a composite of the whole emergency of all emergencies. Emergency room visits have gone up exponentially.
Yeah. No, 100%.
So yes,
sorry.
So I do think even 5% is unacceptable. So any error, I must just preface it by saying any error is unacceptable.
Right.
I mean,
I kind of think the number would be higher, to be honest with you, because when we talk about reportable errors, we're talking about reportable errors, but I wonder how many, and not just in ERs, I mean across medicine, how many errors occur that aren't reported?
Well, but you're thinking smaller errors that maybe don't have
they have no clinical
ramifications.
significance.
Right, kind of like a no harm, no foul, like maybe the incorrect medication was given, but there was no adverse effect, and does somebody report that, I think those things happen more
Do
than
you think
we
it's more than 1 in 20?
I
I
think.
think 1 in 20 is actually about about
You think so?
accurate.
Yeah,
I do.
I don't
I really
know.
do.
I mean, like I've been in surgical cases where there was an incidental injury to a surrounding organ, right?
Yes.
It was fixed, no harm, no foul. I don't know that it was even reported per se.
That's usually reported.
So
I don't know, Dr.
So we,
J.
yeah, so
I don't
we
know,
have,
Dr. J.
we have a pretty stringent, like in my particular hospital, we have a pretty, like very, very strong, like reporting issue. Like even if something is caught, we report it.
And I think it's like that in most hospitals.
Yeah, like because it's also we also see this as a learning issue.
Yeah,
like
right.
we know this is a way to prevent what could have been an actual problem.
Yeah.
So let's go forward with that. And it's not meant to be punitive. It's really meant to be informative. It's just for information.
I
So-
agree with her on that one. I agree with her on that one. Let me ask you a question though. So when it comes to medical errors,
He's like, lean in.
leaning in. So when it comes to medical errors,
Yeah.
is it an equal opportunity offender, or do you think that it's more prone to happen to men versus women, whites versus blacks, old folks versus young folks? Who is the, I don't want to say target because it's not intentional, but who has more medical errors?
So, very generally speaking, I would, I don't know that we can say definitively,
Yeah.
who gets, most
Bad
of the
end of
errors.
that stick, yeah.
But I would say if we were to generalize, probably women, only because I say that women have a lot of their symptoms are atypical. They're not the same symptoms as men. So we tend to look at some of their symptoms and they're very vague. And women will tell me very, very, like, obviously, Doc, I don't know what's wrong. I just don't feel right.
Yeah.
And so I would say that probably women. And then I think that we all come in, into the emergency room. I mean, all of us have our biases.
Yeah. Yeah.
I mean, we're part of the world. And so, black female physicians make up 2% of the population. So, of physicians. So if we're coming into and seeing all comers, I would say that since we are the very low percentage, I would say that black women tend to be, there's issues with us diagnosing and treating. Even when you look at like maternal fetal medicine, you know what I'm saying? Where we're talking about morbidity and mortality when it comes to delivering, to having children, there's just a higher incidence. And I think it's not because it's intentional.
Right.
I just think we all come in with our own, just whatever our biases are, we bring them to work. I mean, we are still human.
And it's interesting that you say that because obviously as OBGYNs, all of our patients are females. And Idris and I will joke about that sometimes where, patients will come in and I'll say, what's going on? And they say, I just don't feel right. But I don't know what's going on. And that's kind of like, as a doctor, you're like,
again.
you're kind of like, yes. But I think it's because you have these atypical presentations. And I tell my patients all of the time, the human body only has so many ways to tell you there's a problem.
Right.
And so a major problem and a minor problem can present very similarly. And I think in women more so. So you're right about that.
Very, very simply.
And I think honestly, I think women tend to be stronger than men. Like men have like,
I'm glad you said that. Yes.
Whereas women, they'll be in pain, like, they don't necessarily endorse as much pain as they're probably having.
Right. And we just can, and let's be real, women just keep on moving. We keep it moving.
Keep it moving.
We have things to do. We have stuff to take care of. And, that little bit of chest pressure, that's just reflux as far as I'm concerned. And it'll go away.
Yeah.
But sometimes it's just, I'm just feeling a little dizzy today. How's that? What's going on? And it can go on for weeks. It can go on for a long time. And then when they present to me, I am now then asked to tease it out because it's been lasting longer than normal.
Yeah.
But I think women are just able to take on a lot of pressure and stress, and it not affect them until it affects them.
Until it's a big deal.
Until it's a big deal.
And so you're talking about chest pain and pressure and kind of just dizzy, these very nebulous symptoms.
Yes.
What are you getting at? 'Cause I think it's one of our number one misdiagnoses in women especially. What were you kind of getting at? What diagnosis were you getting?
We are definitely talking about what we call myocardial infarction or heart attack. I mean, that is the one.
Yeah.
That is it. In my emergency room, I tell everybody that's over the age of 40 that comes in with some nondescript, symptom, fatigue, dizziness, or even abdominal pain. Oh, it's just my reflux. No, everybody gets an EKG. And that's just one way that we just knock that out. Like, we don't even play games.
So can you tell us, for people that are listening, what are the typical heart attack symptoms?
Yes.
And what are some of those atypical heart attack symptoms that people should really be looking for?
Right. So the typical ones are the ones that you see, that you see on TV. You know, I feel like something's sitting on my chest. I'm really short of breath. I don't know why I'm so nauseated. I just cannot, I can't sleep because the pain is so difficult. It's so hard for me to take a deep breath. Those are the main ones. Or the pain going down the shoulder, down the left arm, or going into the shoulder, into the jaw. Those are the typical
That's
ones.
normally the left arm, right?
Yes, yeah. So sometimes
Wait.
they say the left, but it's actually sometimes the right.
I was gonna say,
Yes.
literally, I was gonna say,
Yes.
I read something that said in women,
Yes.
more often they have that atypical presentation where when you're having a heart attack, they have pain in the right arm.
Right.
Yeah.
So you cannot be dismissive of it. So those are the typical. The atypical, as you're getting at, is sometimes they come in complaining of pain in the right side, and you're just like, well, did you pull something? No, I didn't do anything. Did you pick up anything heavy? No. And in addition to that, dizziness. Dizzy. And to me, dizziness is a catch-all. I mean, it's very nebulous.
Yeah.
It could mean anything. It could mean an ear infection. It could mean a sinus infection.
Dehydrated.
It could be
Anemia.
low potassium. I mean, it could mean a stroke. It is those kind of symptoms, fatigue that can't be explained.
Right.
Those are the symptoms that are the atypical ones. Sometimes women don't even have any chest pain. No chest pain. So nothing is actually,
Nothing that tells
no.
you.
Or they'll say something like, well, my back was aching 2 days ago.
Right.
Yeah.
2 days ago, not now.
Yeah, 2 days
but 2
ago.
days ago.
Yeah.
And that's, I think, what makes medicine in general, and probably emergency medicine in particular, so challenging.
So challenging, yes.
Because you're really having to put together puzzle pieces, and the pieces are different depending on the set you get.
Right,
and
that's
the
right.
different set is the different people, right? You know,
Right.
so that's okay. So the top 5 kind of misdiagnoses are heart attack,
Right.
stroke,
Right.
spinal issues, blood clots,
Right.
and like aortic dissections, right?
Right.
And I want to talk about those a little bit more. But first, I just want to ask you this: what if you're a patient, or you're the family
Yes.
member of a patient,
Yes.
and you think that there's possibly been a misdiagnosis, something's
Yes.
been this. Like,
Yes.
how would you encourage patients or family members to advocate for that? Because I feel like, on its face, that's a very awkward situation.
It
You
is.
come to the hospital, you're dealing with the experts, quote unquote.
Yes.
You feel like something's not right, but you don't really have the knowledge base to, legitimize your argument. You just feel like something's not right. How can people advocate for themselves without necessarily, overstepping their bounds?
Okay, so I think that's a great question. So I, in my own practice, like to end my patient's stay with an actual question, speaking to the family and to the patient. Like, do you have any questions?
Right.
So usually when you give them an opening, they will tell you, yeah, I do have a question. How do we explain this? How do we explain this this fatigue that my mom has had that we really have not been able to figure out? So that can sometimes prompt you. So sometimes just me as the physician asking the question, like, what else can I help you with? How can I help you with, and was I clear? So that is one way that I can open that. The second is you just have to advocate for yourself. You have to speak up. You have to say, I feel like there is really something else going on. And most of the time, to me, you know yourself, I'm not going to push back.
Yeah.
And if a physician does push back, my suggestion is if you really feel like this has not been taken care of and there's really an issue, you either can call your primary care physician or you can go see another physician. I am a big advocate of that because,
Yeah.
I know that that's not sometimes the most cost-effective way and the most efficient way, but if you really have not gotten the answers that you want, you have to be your best advocate. You have to speak up.
And I think that's
And-
hard. I find that for me personally, I find there are 2 types of patients.
Yes.
There are the patients that will not advocate for themselves at all.
Yeah, won't say anything.
Won't say a thing.
Yeah.
And then the patients that come in like, I saw this on Google, I got this, and this, and
Yes.
this, kind of like, okay, slow down, let's
Yes.
get your chief complaint first. So
Right.
I find that advocating for yourself is actually very hard. And again, I think usually men have a better time advocating for themselves than women do.
Yes, they do.
And I think minority people especially have a harder time advocating for themselves.
So
That's
yes.
what I find.
So, and you're correct, because I think that there's a lot of, particularly with with people of color, with minority patients, there's been a lot of distrust in terms of the relationship between, medicine and certain patient populations.
Yeah.
There's a distrust,
Yeah.
and there's a way. And sometimes, if you don't see yourself reflected in the people that are taking care of you, sometimes there is a distrust there, and they may not want to get a second opinion from you. They will go somewhere else.
I mean, it's
know.
wild. I've had patients, they come in through the ER, we're evaluating them to see whether or not we need to take them to surgery. And, you're doing your exam and you'll see scars on their belly. And I'm like, what surgery was done? And they'll say, I don't know.
Yes.
And I'll say, I don't know. The doctor said I needed surgery. I got surgery.
Right.
And I'm always
that still gobsmacks me.
Yeah, I'm sorry.
I'm honestly like,
So you had someone cut up on you, like
well, they're like, not someone, it was a doctor.
It was a doctor.
I knew him. I knew who it was.
You had a doctor cut up on you. You went to sleep. They put you under. And there were times when you like you say there could be several scars.
Yeah.
And I'm like, do you know what happened there? I don't know. Can you call my daughter? And then because they don't know.
Yeah.
And then you have to make that extra step.
Yeah.
To find out, and I ask that extra question, and be like, and it happens all of the time.
Yeah. No, you're 100% right. I mean, people have to advocate for themselves, and you're right. You either have the people who just will not, they trust you implicitly,
yeah.
which I appreciate to an extent, but don't, And they have the other people who don't. I had a patient come in once, she needed hormone replacement, and she brought the Suzanne Summers book, and she had pages dog-eared and paragraphs highlighted, and she said, "Doc, you need to read this. I'll be back next week. We're going to talk about my hormone replacement."
Read pages 25 through 73.
Yeah,
and I want a 2-page report.
Yeah, and I was like, I'm like, will do, And so there's this balance, right? But
So that's the thing, it's too much advocating, is what you're saying.
Right. And also, like you said, with the internet, with everybody being able to Google their
ChatGPT
their
says.
yes, and that has put something something else into the mix, right? That's just thrown another kink in the whole pot, and you're just like, oh, okay. So what did Dr. Google tell you? What did they say? What did it say?
On our social media, we have a whole Dr. Google thing we do. It's quite disheveled and confused, but another story for another time. But okay, so there are 4 other diagnoses that I wanted to get to. I don't think we're going to, but okay. So stroke.
Yes.
What are some common symptoms of stroke that people should look out for?
Okay, so the common symptoms are the ones that are really obvious to you. So, the slurred speech, the inability to find your words, the droopy face, the face that is like
I was like, inability to find my words. I'm in trouble.
The really bad headache that won't go away. And usually they come in with sudden onset, so it just came out of nowhere. This is not a migraine, this came out of nowhere, and it's sudden onset. So those are the common ones, and also balance, and also being able to having a weakness, usually on just one side. It's not a general weakness, it's usually on one side, and you can see it's pretty obvious.
And that's what I was going to ask you, because I think people don't think of stroke unless there's some type of asymmetry. Like there's weakness or slurred speech. If they don't see that, it's not a stroke.
Right. And that is not true.
Yeah.
Those are the common symptoms. And then you have the atypical ones, the ones that lead to misdiagnoses. Right. And the common ones are, once again, dizziness. Because dizziness that could be anything. It's part of what we call the vestibular system. It's part of the inner ear, but it's also part of the back part of your head brain that has the posterior, what we call it the posterior circulation. So dizziness in somebody, I'll say over the age of 50, that could mean anything. But those are dizziness, nausea. It just once again, very general. Generally, fatigue again, not acting right.
And so, because I would imagine a patient's not going to come in saying, "I'm not acting right." Is that a situation where you see like the husband or the wife or the kid saying like, "Mom is off, like something's wrong"?
Yes. So it's usually like a caregiver. It's usually somebody a daughter. To be honest with you, that comes in and says, "My mom's not acting right. My dad's not acting right. I take care of him or her every day, and something's off."
Well, when our granddad had a stroke, there were little signs. He was clipping cars when he was driving, and he kept saying, "I don't know what's happening to my car," and then little signs, they were like, and it turned out he'd had a stroke,
Yes.
But okay, well, let me ask you about this, and then we're gonna have to go. But so clots.
Yes.
One of the most commonly misdiagnosed conditions is blood clots, legs, lungs.
Yes.
Who's at risk for that, and what should they look out for?
Okay, so generally, unfortunately, women are fairly higher risk than men.
And it's the whole estrogen.
And it's hormonal related. It's usually women who are also taking birth control or hormone replacement. Yeah. We're also dealing with people who are dealing with. I'm always a red flag for me is also somebody who has cancer, who's actively having cancer, or who has recently come out of cancer. That is also, or are you coming off of a long trip? Have you been on? I deal with a lot of where I'm at. I'm in southern rural Georgia. There are a lot of truck drivers. So if you're taking these long haul trips, when you come into saying that, I've had a little bit of discomfort in my chest, funny feeling in my chest.
How does it present?
Oh,
What are
funny.
the symptoms? What should they be looking for?
Usually they're just saying I'm really short of breath.
Yeah.
And without any other reason for being short of breath. They don't have a cough. They don't have a fever. And they don't have heart or lung disease. Or they may have those things, but it doesn't present, they haven't had a problem with that in a very long time.
Yeah.
So those are the common things. And then what I will see on exam is that they have really fast heart rates for no reason other than it's fast. So there's no fever.
Yeah.
There's nothing else to read. They're not dehydrated.
Yeah.
They haven't been running a marathon. They haven't been exercising. So those are and those are the things that I look for and make sure that, if I see that, those are red flags for me. And then I just run the tests that, end up, showing me that. And basically, we've gotten really far in terms of testing. So you can do things like, blood work and then a CAT scan. Those things that can really be done, that can rule those things out, and ultrasounds.
Interesting.
So,
Well, we're going to have to do this again. Like, literally, we're going to have to do this again. I don't know if we're going to have to bring you on Zoom or if you just want to move up to Chicago and hang out with us.
I'm going to go down. Let's go to Georgia. I want to go to Georgia. Let's do this remotely.
Road trip. We'll come there with blood clots like Mana.
Yeah. I'm a little short of breath and he's dizzy.
I'll be like, oh, really?
So where can people find you?
Okay.
Any place that they can find you? You do anything like on social media?
She's in the ER 24/7. 24/7.
I am in the emergency room. I work at Phoebe Worth in Southwest Georgia.
Are you on social media?
And I am
Can they find you?
I am on LinkedIn.
Okay, all right.
So professional.
Inquiries only.
Wait, are you going to stick around with us for this next segment?
If you want me to,
We do.
I would love to.
All right.
I would love to.
We do. Okay,
Absolutely.
so our next segment, guys, is going to be our Doctor, What's in the News. So like I said, we normally open with that, but we're going to do it now with Dr. K and Dr. I. And we've got two of our friends who've been on previous shows. Michael Johnson from Michael Johnson LLC, who does healthcare law. We've got Zin Chan, board certified pediatrician, and he's also a healthcare administrator.
Are you dizzy?
So, I'm dizzy.
You lost your words.
I'm getting my words out. So that's going to be coming up next. All right, guys, so what's in the news? It's the big, beautiful bill that is in the news. So you guys have probably heard about it. It's nearly 900 pages, and it's going to affect every aspect of American life. But our focus is its effect on healthcare and health education. And to discuss this, we've still got our buddy Dr. K here, and we've got our buddy Dr. Zin Chan. You guys already know him. You've seen him before, but he's a board certified. Okay, I can't find my words again.
Seriously, help this man. Help this man.
No, he's a board certified pediatrician and a healthcare administrator. And he's going to help us kind of break this down. So welcome again.
How you guys doing? Good to be here.
We're
to see you
good.
again.
We're good. So, Zen, what are your general thoughts about? I know, right? He's like, the general thoughts about the 900-page bill. Thanks for setting me up, man. But what are just your general thoughts about the bill as it might affect healthcare?
Sure. Well, the bill, the biggest impact is the near $1 trillion cuts to Medicaid and also some commercial insurance spending over the next decade. And when we think of how necessary Medicaid is to provide that safety net for healthcare in the country, cutting that much money out of that system is going to end up just with a lot of people losing their coverage and losing their ability to get care. Right. That's my just 50-foot, high-level, one-liner view of the situation.
Right. And so I just wanted a cool question. So you mentioned the Medicaid cuts, which a lot of us have heard about, but you said something about commercial insurance spending being cut. Can you tell us a little bit about that?
Yeah, there was I don't know the exact precise details, but there's about 150 million, I want to say, that's going to be taken away from provisions to commercial insurance as well. So there's going to be needing some retooling in the different types of risk arrangements and value-based care arrangements and all the fee-for-service payments that are going to be given out to providers, to healthcare organizations from private insurance as well. However, the big impact is going to be from the Medicaid side.
Yeah. And just for people who don't know, Medicaid is basically federally funded medical insurance for underprivileged people. And so when we're talking about there being $1 trillion in Medicaid cuts and some of the stats say that about 8 million people are probably going to be bounced off of the Medicaid rolls.
Probably
More.
more, yeah.
Yes.
More.
More, probably
It
more.
means that there's going to be a lot of folks out there who don't have medical insurance. So it seems like a pretty obvious question, but do you think that this is going to lead to more healthcare discrepancies, or not discrepancies, but disparities? Thank you.
Yeah.
More healthcare disparities in the U.S.
Yeah, oh, absolutely. I mean, we already have such a tremendous level of disparity based on wealth, based on race, based on so many different factors. And of course, when you pull that rug that's holding everybody on from the low-income individuals, from those that are disabled, or maybe from undocumented populations, whatever it is that's been using Medicaid, you're going to see a lot of people lose that healthcare coverage. And that impact sort of has a trickle-down effect, right? Like there's a downstream effect to that. Because if you are not going to have your health insurance anymore, you're probably going to be seeing your primary care doctors less. And what happens if you see your primary care doctors less? I mean, think children. Note, like your vaccination rates go down, your preventative care measures go down for kids who are, suffering from chronic diseases. How are they going to get their care? And the only safety net that still remains, and I heard you guys talk about this before, it's the ER, it's the emergency room.
Yep,
and so we're going to see that overcrowding happen
Yes.
even more than it already exists. We're going to see those wait times go up,
That's
and
right.
that has an impact, right, continuing downstream on the rest of the community. Because everybody else is trying to go to the ER for your appendicitis, your MIs, your strokes, all these kinds of things. And then you're just going to get a lot of these individuals that are going to the ER for more urgent care, primary care type concerns.
And I think one thing that people don't think about as well, so a lot of folks are just going to lose their Medicaid off the bat, right? But then for people that still have their Medicaid, they're going to be these work requirements, right? They're going to have to work 80 hours a week a month, and 8 hours a week. That's like doctors. They're going to have to work 8 hours a month in some type of meaningful activity, whatever that means.
Yeah.
But for a lot of folks that have Medicaid, it's not that they're not working, they're working and working a lot. They just don't have insurance. So a lot of people may not be able to do an additional 80 hours of meaningful activity in addition to what they're doing per month. How do you think that's going to affect? Are we going to see even more people bounce off the Medicaid because they get their Medicaid, but then they're not meeting this work requirement?
Well, you made the excellent point right there, is that a lot of these individuals are working. It's just, even the documentation burden, the reporting burden, and it's funny to talk about documentation, not in the sense of like physician charting, but the documentation burden on the general public to report, and they're increasing the reporting frequency from every year to every 6 months. So to do all of that, to navigate the systems, which those portals are going to be awful to use and are going to shut down all the time. People are going to lose their coverage simply because of how difficult it may be to navigate these portals, navigate that reporting system. Think anybody who has low health literacy, anybody who may not speak English as their first language, anybody who may not be technology native. These are all people that will be affected by this, and they may already still be working to doing more than 80 hours a month of work already. And so, we'll see more people sort of lose coverage just naturally from there. I want to make the point that I believe in, maybe I might get the year wrong, but 2018, I think Arkansas tried something out already where they were implementing work requirements, and all they saw were 18,000 people lose their coverage, and there was no bump, no increase in the level of productivity or people working or anything. So it was a failed attempt. And I know other states have tried that as well. Don't know the full scope of the results, but I just think people are going to lose coverage, and we're not going to be seeing that increased work.
And I heard some states that, because it's going to be jurisdiction by jurisdiction, some states may require it monthly. They're saying that some states may require you to do whatever documentation is required monthly. So,
Depending on where you're at.
yeah.
I didn't realize we were reinventing the wheel, so some states have already done this as well, and it's failed.
Yes, and I can speak to that. There are the patients that I see, they're on Medicaid, but they do work. There are people who have 2 and 3 jobs. They just can't, they don't make enough to, be able to make ends meet. So then we're going to have people to making really odd decisions about what they're going to eat and where they're going to get medical care. Yeah. And the fact is, people who get bumped off of Medicaid are still going to need care.
Yeah, right.
They're just going to come to the emergency room, and they're going to be coming sicker. They're going to be coming with their chronic diseases, but they're going to wait longer. Yeah. So we're going to actually see a bump in emergency room visits, and also sicker people are going to show up.
And that kind of leads to my next question. So it sounds like the big beautiful bill may have some pretty adverse effects on people and healthcare availability and community health. What kind of effects do you think it may have on hospitals and hospital systems, though? Because a lot of hospitals are on very thin margins, very thin margins. How might this affect hospitals and healthcare systems as well?
Sure. I mean, so much of your revenue is based off of just the dollars you're bringing in from Medicare, from private insurance, from Medicaid. And, there is a gamut of hospitals that rely on Medicaid a lot more than others. And I think, in most situations, it's the children's hospitals and it's the rural health hospitals and health systems that rely on Medicaid as a higher portion of their revenues. So they're going to be hurting when they lose that revenue stream. And then they're also going to be seeing a higher level of uncompensated care. So they're still going to have to go through the costs and expenses of treating patients because they're coming to the emergency rooms and overutilizing that avenue. Hospitalizations will continue to be there, but they will be uncompensated because they're uninsured and have to take it out of their own bottom line.
Yeah, I read they're estimating $204 billion in uncompensated care
I
over the
think
next.
that's an underestimate. I think
I think that's
a
highly
gross
underestimated,
underestimate.
and we know that particularly hospitals in rural places, regardless of what state you're in, their hospitals are going to close. In fact, I think that their hospitals are already saying that they're going to close, just knowing that they cannot, knowing that they cannot meet that shortfall.
Well,
They will not be able to.
They're guesstimating that 300 hospitals in rural and underserved areas are going to close as a result of this. So.
Absolutely. And so then when those close, where do people still go?
That's a very good question.
They still go to the same places that everybody else goes to.
Yeah.
But it will put a strain on us in a way that I don't know that we can really imagine at this point. That's just my thinking.
Oh, I 100% agree. I wanted to add that 300 number, I don't even think that 300 number is because of this bill. Yes. I think that 300 number is going to go up because of this bill.
For sure.
Right.
Right now, there are about 1,800. I just looked at this number very recently. There were estimated 1,800 rural hospitals in the country. About 768, so over 750, are at risk of near-term closure. Somewhere in the next 3 years are in the risk of near-term closure. 40% of that, imminent closure within the next year. And you add on, you take away that extra revenue stream, like I mentioned earlier, from Medicaid. I think that number is going to go up, and we're going to see a little bit of a difference in this projection again.
For sure. And I think the part of the story we haven't discussed as well is undocumented immigrants, right? Because undocumented immigrants in a lot of states still qualify for Medicaid. And I know we were talking earlier, you're saying that you have a pretty high population of undocumented immigrants. We have I would say, maybe 15-20% of the patients our hospitals serve, if not more, are undocumented immigrants. And again, they're not going to disappear. They're not going to stop becoming pregnant. They're not going to stop having heart attacks. They're just not going to have Medicaid. So they will still come and they will still be cared for, but they will not be able to pay. And the hospitals will be paying for that as well.
It's going to put a big burden on the system. And I think, maybe a good way to wrap it up is to say this. People are going to come for care.
Yes.
Because they're going to need care. The rest of the country is going to kind of take on the brunt of that expense. What ends up happening is people who are paying for medical care through medical insurance, the hospitals are going to say, like, look, this is what we need to survive, so we're going to charge more to those people who are paying.
Right.
And so the cost of healthcare is going to go up. That means the cost of your insurance premiums are going to go up, and I think it's just going to kind of
your employers will cover less because their costs are going to go up. It's just going to be a both.
Your deductibles will go up. I mean, it's just going to be a whole thing.
It's going to be interesting.
And then also, let's think about children as well. We talk about taking care of our children, and 50% of children are covered by Medicaid in this country. So what's going to happen there? Like you mentioned, vaccination rates are already starting to kind of act, are not as good as they could be, so that could go down. And then just taking general care, kids with asthma. I mean, this is going to be a really issue for children as well. And I think we need to really be aware of that and just know that.
Something we're definitely going to have to keep an eye on it. So we know some folks we can call. Zen, we're going to be calling you again. And thank you so much for coming on.
Awesome, thank you for having me.
Hey, we'll be in touch again soon. Now we're going to go to our buddy Michael Johnson of Michael Johnson LLC. He is a healthcare attorney. He's also married to a doctor, so he's both a lawyer.
Friendly. He's doctor friendly.
He's physician adjacent. He's physician adjacent. And we want to get his thoughts on the big, beautiful bill. Oh, and there he is. Hey, Mike, what's going on?
Hi, how's it going?
It's going,
Good,
it's going. So I don't know if you were able to hear our conversation or not, but I'd like to. Perfect. Okay. I'd like to start just by getting. I'm going to put you on the spot.
Your 35,000 foot impression.
What's your 35,000 foot view of this 900-page bill? No, but as it applies to health and healthcare and potentially healthcare education.
Yeah. So there were two kind of big things that affect physicians. My law practice is helping physicians evaluate, negotiate employment contracts. So like I'm kind of at the core of how physicians contract for their work and how hospital systems, pay physicians. Two big issues. One is the Medicaid cuts, and then two is the caps on how much federal support will come in for medical education.
Yeah.
Okay. The amount of student loans that physicians are bringing on is quite substantial. The cost of pursuing a medical education is growing a lot.
Yeah, that was
we usually should do something about that, okay, instead of cutting the amount of funding that's available for folks that want to be physicians. But it's not uncommon for physicians to come out with $300,000, $400,000, even $500,000 in student
Yes.
debt, all in, to get to the point of becoming a doctor.
Have
This
MD
new
will work for
bill
food.
caps the amount. Yeah, it's a substantial amount. It's massive. We live this in our own house, by the way. But the amount of federal support for these student loans is now going to be capped at $50,000 a year and only for 4 years. So that's $200,000. So you imagine you have $200K in support from federal sources, and now folks going into medical school have to cover the rest of it through either family paying, which is going to be very challenging for anybody middle income or less, okay, or go get private loans that are going to have much more challenging rates and terms. It's going to be more difficult for them to pay back those loans. So we're essentially increasing the amount that it is costing to become a physician, okay? And then on the other side, with Medicaid cuts, we are decreasing the amount of revenues that are available to pay physicians. So this is a double whammy that is going to have an impact. I hope over the next couple of years, a lot of this bill is reversed through various other, legislative proposals, but we have some problems.
I think a big part of it, though, also, it's going to be harder for folks to go to med school, but I think you're going to see a different type of person going to med school, okay? Because I'm going to tell you a little story. So I decided I wanted to go to flight school. So I applied for a loan like a few months ago, okay? And I've got a crap ton of credit card debt and medical school debt, but I've got a good credit score.
Yes.
They declined me. They said, get a cosigner, okay? And I'm damn near 50 with a job making decent money, okay? So I think when we have people that aren't able to get federally guaranteed loans, they're gonna have to go to private institutions. They may not qualify,
That's
okay?
right.
And so I think you're gonna see a lot less of a variety of people who are able to even get a medical school education.
Well, not only that, and they may make different decisions if they do go to medical school. They're going to make more financially driven decisions about where they practice, what they practice. They may not spend as much how they practice. They may not spend as much time on research, which is super important, but doesn't pay well, And so I think the ramifications are potentially enormous.
Actually devastating, because we talk about primary care, right? And that's what we need. That's what we need. That's what we need. And so we're involved in primary care. Who's going to go into those fields? Who's going to, who's going to want to deliver babies? Who's going to want to take care of children? Pediatricians. Who's going to want to go into the fields where you may not be compensated in the way that you need to be able to pay back these loans?
Yeah. And you raised a good point. Most people are finishing med school with enormous debt. I know for myself, I was certainly north of $300,000 in debt.
Easily.
And when you go to private schools,
Yes.
you're going to have that debt. I know you were telling me you and your wife went to private schools. This is a reality of going to professional schools, and it's going to make people probably think
Twice.
3, 4, 5, 6 times about
Yeah.
whether or not this is
Worth
the
it.
route for me. Yeah, 100%.
Right.
Well,
Absolutely.
Mike, hey man, thanks for joining us again. As always, we're going to be calling on you again real soon, so keep your phone close, okay?
Appreciate y'all.
All right, see you soon.
Thank
Thanks.
you.
All right, guys, well, this appointment's almost over, but first, today's gross anatomy session, and it comes from England, where a young girl was born with her heart outside of her chest. It's called ectopia cordis. And they're gonna
Doctors in the UK have successfully operated on a newborn baby who was born with her heart outside of her body. Vanellope Hope Wilkins was born on November 22nd with an incredibly rare condition called ectopia cordis. Babies born with the condition have less than a 10% chance of survival and are at risk of a whole host of potential health problems. Early on in the pregnancy, parents Naomi Finley and Dean Wilkins tested to see whether their child was at risk for 3 severe chromosomal abnormalities. The results showed their baby was at low risk, and they decided to go forward and plan for the surgery to be performed shortly after Vanellope was delivered. Surgeons at Glenfield Hospital in Leicester immediately wrapped the baby in a sterile bag, and at around 1 hour after birth, she was stable enough to undergo the procedure. Using a special splint to open up a chest cavity, doctors repositioned her heart, created space for the organ, and gravity did its job, allowing the heart to sink into her chest over a course of 2 weeks.
If you saw when she was first born to where she is now and what they've done, it's
beyond a miracle, isn't it?
The surgery was a first for the UK.
Thankfully, ectopia cordis is rare. It affects only 0.0000006% of babies. But while rare, it's very deadly. Only 10% of babies survive more than a few days after being born with the condition. So, if you guys didn't know the babies could be born with their hearts literally outside of their chests exposed, now you know, and that is today's Gross Anatomy.
All right, I am Dr. I.
I am Dr. J.
And this is Dr. K.
Now, before you guys head for that waiting room, stop by the receptionist desk, and don't forget to make your next appointment for Second Opinion with the Twin Doctors
And Dr. K.
See you guys later.
Thank you.